1.4 billion. I mean, just take a second and let that number really sink in, okay? Right now, all across the globe, 1.4 billion people are just walking around with hypertension. It's like this massive silent powder keg sitting there in the background of everyday life, just waiting for the right spark to set it off. Hey everyone, and welcome to This Explainer. Today, we're diving into a topic that is quite literally a matter of life and death. We're going to completely demystify hypertensive emergencies, and we'll do it by breaking down the absolute latest clinical guidelines for 2024 and 2025. It's going to be an awesome deep dive, so let's get right into it. Okay, here's our roadmap for today. We'll quickly hit on the global and local threat scale, then move into understanding hypertensive emergencies, the cycle of target organ damage, identifying triggers, accurate blood pressure measurement, and finally, blood pressure reduction targets. Let's roll. Starting off with Section 1, the global and local threat scale. So, looking at the 2024 World Health Organization data, they estimate that a staggering 33% of the world's population between 30 and 79 years old, yep, that's that 1.4 billion number we just talked about, has hypertension. And you know what? The local reality mirrors this global threat perfectly. Take Indonesia's SCITS-HI 2023 survey data, for example. It shows a local prevalence of 34.11% in adults over 18. We're talking about more than a third of the adult population being at risk here. That's huge. All right, moving to Section 2, understanding hypertensive emergencies. So what exactly is a hypertensive emergency? Well, it's an acute cardiovascular condition. Basically, a severe elevation in blood pressure that leads to acute, potentially fatal damage to target organs, mainly the brain, the heart, and the kidneys. Now listen, I really want to emphasize that phrase, target organ damage. An emergency isn't just, seeing scary high numbers on a monitor. It is defined by actual, acute, irreversible organ damage that is happening right then and there in real time. And that's exactly what separates it from a patient who just has severe high blood pressure, but absolutely no symptoms. Now you might be wondering where we're getting our game plan. The action plan we're laying out today comes directly from the absolute top authorities in cardiovascular health. We're talking frameworks endorsed by the 2024 European Society of Cardiology, or ESG guidelines, and the brand spanking new 2025 American Heart Association, or AHA guidelines. Check out this AHA diagnostic flowchart. Notice how the deciding factor for an inpatient with markedly elevated blood pressure, so that's a systolic over 180 or a diastolic over 110 to 120, the deciding factor is whether there is new or worsening target organ damage. If the answer is yes, you are in the red zone. It's a full-blown hypertensive emergency. But if the answer is no, then you're just dealing with asymptomatic, markedly elevated blood pressure. And as you know, that requires a completely different clinical response. That brings us to Section 3, the cycle of target organ damage. And wow, is this a terrifying, vicious cycle. It's like a deadly domino effect. It starts with climbing blood pressure, which causes vascular injury and constriction. That constriction, it leads to ischemia, which is basically starving the tissues of blood flow and oxygen. So what does the body do when it senses this sudden drop in blood flow? It totally panics. It activates the RAS system to crank the blood pressure up even higher, which of course triggers inflammation, thrombotic microangiopathy, and more vascular hypertrophy. Basically, the body locks itself into this accelerating loop of malignant hypertension and multi-organ damage. It just feeds on itself. So how does this internal meltdown actually look on the outside? Neurologically speaking, a patient might come in with a severe headache, confusion, seizures, or focal deficits. We have to be on super high alert here for devastating complications like hypertensive encephalopathy, ischemic strokes, or intracerebral hemorrhage. On the cardiovascular side, all that immense pressure causes chest pain, dyspnea, and palpitations. When you see that, it means the heart is rapidly breaking down under the strain, pointing straight toward acute coronary syndrome, acute heart failure, or cardiogenic pulmonary edema. And unfortunately, it doesn't stop there. This damage spreads like wildfire to other systems. For the kidneys, you've got to watch for decreased urine output, like oliguria or hematuria, which are massive red flags for acute kidney failure. For the eyes, sudden blurred vision could mean retinal hemorrhage or papilledema. And we absolutely cannot ignore the unique, severe complications that can happen during pregnancy. Symptoms like severe headaches, epigastric pain, or nausea, they can instantly escalate into severe preeclampsia, eclampsia, or even placental abruption. All right, moving into Section 4, identifying triggers. Whether a patient has uncontrolled primary or secondary hypertension, these emergencies almost never happen in a vacuum. There's almost always a trigger. And the most common one? Just simple noncompliance with antihypertensive meds. But it can also be acute or chronic kidney disease, endocrinological issues like hyperaldosteronism, or the use of illicit sympathetic stimulants, things like cocaine or amphetamines. Oh, and keep a close eye on drug interactions. Even something as common as taking NSAIDs can trigger a massive spike in blood pressure. It's also super important to remember that elevated readings can be triggered directly by the patient themselves. Biological responses or acute distress, like sudden pain or severe anxiety, will aggressively drive up plasma cortisol and catecholamine levels. On top of that, the hospital environment itself can be a trigger. Things like sleep deprivation from poor sleep hygiene in the ward, or maybe the fact that their home medications were discontinued the moment they were admitted, these factors can artificially and drastically spike a patient's readings. Okay, let's look at Section 5. Accurate blood pressure measurement. Now, this is absolutely crucial. A flawed reading could mean misdiagnosing a crisis, or honestly worse, actively treating an emergency that simply isn't there. The guidelines are incredibly strict about this for a reason. 1. The patient must rest for 5 minutes without talking. 2. They need to have an empty bladder. 3. You've got to use the correct cuff size on a bare arm, supported right at heart level. 4. Their back must be supported by a chair. And 5, their feet have to be completely flat on the floor with their legs uncrossed. If even one of these physical requirements isn't met, the reading is compromised. Simple as that. And these rigorous protocols, they absolutely extend to home blood pressure monitoring too. Feet flat, back supported, arm at heart level, the whole shebang. Crucially though, you should know that readings taken at home or via ambulatory monitoring are usually lower than office readings. Why? Because the patient isn't experiencing that clinical anxiety. The classic white coat effect that we constantly see in healthcare facilities. Which leads us right into our final area, Section 6, blood pressure reduction targets. When you're actually treating these emergencies, remember this: one size definitely does not fit all. For a general hypertensive emergency without any special conditions, the standard protocol is a gradual, controlled reduction. You want to lower the blood pressure by about 25% in the first hour, and then carefully bring it down to under 160/100 over the next 6 hours. But let's contrast that with something like an acute aortic dissection. In that specific scenario, you have to be incredibly aggressive. You need to instantly drop that systolic pressure to under 120 millimeters of mercury to literally stop the aorta from tearing any further. It's night and day. Managing these crises requires absolute pinpoint accuracy, and it's all based on the specific organ damage at play. Take an ischemic stroke without thrombolysis, for example. You actually do not actively lower the blood pressure if it's under 220/120. Sounds a bit counterintuitive, right? But the brain desperately needs that perfusion pressure to survive. Compare that to severe preeclampsia. There, the protocol demands an immediate aggressive reduction to a systolic under 160 and a diastolic under 110/105. The specific condition always dictates the speed and the target. So what does this all mean for us? We've seen the massive global scale, we've broken down that vicious cycle of organ damage, and we've looked at the incredibly precise, razor-thin margins for treatment. So I'm going to leave you with this to ponder. Is your frontline medical team truly ready to instantly differentiate a harmless high blood pressure spike from an active, silent organ-destroying emergency? The 2024 and 2025 guidelines are out, the protocols are crystal clear, but the actual execution, well, that's entirely up to you. Thanks so much for hanging out with me for this explainer, and keep learning.